Hi guys, my name is Diamond, and this evening I will be talking to you guys about coagulation disorders, factor V, Leiden, and protein S and C deficiency. All right, so factor V Leiden deficiency is a genetic mutation of the factor V causing an elimination of cleavage at the factor F5 site. This in return causes an individual to develop life-threatening blood clots. It should be noted that not every individual who carries the gene will have a venous thrombotic event, but instead present incomplete penetrance, no disease, because they have the autosomal dominant recessive gene. Protein S and C deficiency is the loss of anticoagulant properties resulting in thromboembolism and unchecked thrombin due to the inability of maintaining physiologic homeostasis. So basically, both of these disorders are a clotting factor issue that can cause an individual to develop blood clots. Risk factors, maternal consequences, and neonatal consequences for the factor V Leiden. The risk factors are personal and family history, contraceptive use, primarily oral, pregnancy, and postpartum. Other factors include travel, obesity, surgery, injury, and catheter use. Maternal consequences are women with inherited disorder are at a greater risk of thrombotic events and related complications during pregnancy. The Leiden variants correlated with increased risk of antepartum recurrence. That means basically they have the issue during pregnancy. If they have already had a thrombotic event, they have the higher risk factor of having an antepartum recurrence when carrying a baby. They also have they have pregnancy loss, preeclampsia, placental insufficiency, and placental abruption due to clots forming inside of the placenta. Thromboembolism affects 1.2 out of 1,000 deliveries, increasing morbidity and mortality rates in women. Fetal consequences are fetal growth restriction, fetal loss, placental abruption, and stillbirth. For protein S and C deficiency, their risk factors include inflammation, infection, malignancies, liver, disease, chemotherapy, DIC, vitamin K deficient, or on a vitamin K antagonist, or it's inherited. So protein S and C deficiency can either be acquired or inherited. Maternal consequences include placental insufficiency, miscarriage, clots in the placenta, and pregnancy loss. For the fetus, they can have apnea, intracranial hemorrhage, bilateral retinal detachment, and purpura fulminans, which basically are lesions that develop on the fetus that can eventually turn necrotic into black, basically sloughing of the skin, but definitely can be fixed, as you should say. So subjective and objective data for factor V Leiden as well as protein S and C deficiency. So subjective for factor V basically is asymptomatic. The individual can be unaware of them having or carrying this disorder, but if clots do start to form in the lungs, they get a sudden shortness of breath, chest pain when breathing, rapid heartbeat, and coughing that includes a bloody sputum or coughing up blood in a sense. For their objective factors, you can see blood clots during pregnancy or with the use of oral contraceptives. In the legs, you will see pain, swelling, redness, and warmth. So this would be a great way to educate your patient to say, hey, if you ever notice like, man, my legs are swelling, you get like this ache or a crampy feeling in your leg, it doesn't go away with whatever you try to do to alleviate it. It's red, it's warm, definitely an indication of a blood clot. Protein S and C deficiency is asymptomatic. Throughout their data, they really didn't specify what subjective underlying findings would that person be able to state that is going on. And then for their objective factor, you can have DIC, the purpura fulminans, which I explained were the darkening of the skin with lesions, DVTs, and PEs, which are pulmonary embolisms. Three differentials. So factor V, you can have a prothrombin-related thrombophilia, which are venous thrombotic events presented as asymptomatic DVTs in the legs or pulmonary embolism. You can have an inherited abnormalities, which are protein S and C. They're not really, you don't really hear about protein S and C disorders. They're very low in people who have blood disorders, but they are protein deficiencies found in individuals who exhibit VTEs. They are typically less common. And then you have hereditary dysfibrinogenemias. Let's try saying that 3 times. They are a rare disorder causing thrombosis and thrombophilia. Protein S deficiency has antithrombin deficiency, which is a hereditary blood disorder that's an inhibitor for activated coagulation factor 2A, factor X10A, and factor 9A. Prothrombin mutation is an inherited blood clot disorder that manifests as DVTs in the legs or PEs as well. And then, of course, factor 5 Leiden can be a differential, which is a mutation of the factor 5 gene causing abnormal blood clots in the lungs and the legs. So as you see, the 2 disorders, deficiencies, they kind of overlap one another, factor 5 and protein S and C deficiency. The whole depth of this is that you have a hematologic disorder with a clotting factor. So diagnostic tests 1. So for factor 5, you would definitely do a screening test, also known as the APC blood test. This is the activated protein breakdown clot, and if resistance is indicated as a result of the test, then an individual is on surveillance for the factor 5 mutation or the factor 5 Leiden disorder. For protein C, you can do a functional assay, which is used to identify both type 1 and 2 disorder, which is most preferred. Protein S functional assay is measured by the clot-based assay. The amount of protein presented is equivalent to the time of the clot formation. So these are the first diagnostic tests that you would do to indicate whether or not the patient does have an underlying disorder. Diagnostic test 2 for factor 5 is a DNA genetic test is done to confirm the screening test of the APC results. This excludes the factor 5 gene. What they do is they take the factor 5 gene, they examine the gene code for a mutation. This is definitive if whether the person has the heterozygotes, which is one of the genes, versus the homozygotes, which you have both, like both parents are the carrying factor, versus hetero, which you only have one. So this test is only definitive and done based off the results of the APC. For protein S, you can do the total protein S, which is an antibody-based method, or for protein C, you can do the immunoassay, which distinguishes the difference, again, between type 1 and type 2. And then for diagnostic test 3, there really wasn't one specified for factor 5 Leiden, but for the protein S and C deficiency, you can do a mutational analysis, which is basically the PROC1. This testing is done after initial testing that highlights the protein C deficiency. This test provides understanding of the disease. You can also do genetic counseling as well as PROS1, which is done after the initial test that concludes protein S deficiency is prevalent and presented. So these tests, again, are done in addition to the other testing that I spoke about, just to basically specify that, yes, the patient has this disorder and they have either type 1, type 2, or the specific disorder. So pharmacologic and non-pharmacologic treatments for factor 5 Leiden. So the standard is oral anticoagulants. You see this in apixaban, dabigatran, because of the lower risk of bleeding and the convenience. So factor 5 oral standards are something that they typically use to help with that disorder. Oral anticoagulants are prescribed based on adherence, the severity, and the drug interactions. So again, it's very important for not only the prescribing doctor and the provider, they also need to talk to pharmacy, basically get a team together to really look over the patient, the situation, the severity of the disorder, that whether they're pregnant or not pregnant, and then other medications that the patient may be taking to ensure that the specific oral anticoagulant that the patient is being prescribed does not interact with other drugs. Warfarin is concurrent with low molecular weight heparin and monitored by lab draws of INR. So when an individual is pregnant and they're in postpartum with breastfeeding, you're not going to be on an oral anticoagulant. You will be on a low molecular weight heparin, and sometimes in addition to warfarin. Prophylaxis is suggested when you're during postpartum and definitely breastfeeding, because you have to make sure that the medication you're on is not being passed on to the fetus. Well, at that point, the baby. Individuals should be on maintenance therapy to avoid life-threatening venous thromboembolism or recurrence of VTE. Again, this is definitely going to be something that you speak about with your follow-up if you are diagnosed with a disorder, especially when pregnant and then wanting to be pregnant again. Recurrence definitely does happen for individuals with blood clots in their forming. So a lot of times individuals are on a maintenance therapy to avoid recurrence, avoid thromboembolisms and VTE from happening. The non-pharmacologic aspect that you can take are compression stockings, filters, IVC filters are something that can be placed. Intermittent compression devices, those are those little leg pumps that you see a lot of patients with. Mobility, the more mobile you are, the more walking you do definitely assists with not forming those blood clots. That is why a lot of times mothers are educated to make sure they're up and they're moving, they're being mobile, they're getting out of bed. You're even though how painful it may be, if you had a C-section, you are moving to make sure you're not forming these blood clots. And then exercise is another thing that's important. Diet. You definitely, when you're on these anticoagulants, you have to monitor your vitamin K intake, which are your, as we like to call them, those green leafy vegetables, your salads, your greens. You definitely want to monitor your intake because you want to be on a therapeutic range when you're on these anticoagulants. And a lot of times what you intake can definitely throw off your INR. So when you get your lab draws, your numbers are not right. Doctors are screaming at you. You got to change your doses to make sure that you stay in that therapeutic range. For protein S and C deficiency, anticoagulation with heparin in addition to warfarin. So again, as you can see, that they kind of resemble one another. You're going to, again, be on an anticoagulant. A lot of times it's going to be the low molecular weight heparin in addition to the warfarin. So protein C, you concentrate as replacement therapy for protein C. Protein C concentrate is definitely used a lot of times to assist with their protein C deficiency. And that's seen a lot with even with the neonatals who get this deficiency and get that purpura fulminant, that darkening of the skin, the lesion that can form. It was a case study that I read that the newborn was given the protein C and it definitely did help with their recovery. Protein S, again, is with a low molecular weight heparin with vitamin K antagonist. And then a lot of times with the newborns, they will be given fresh frozen plasma to assist with the disorder. Non-pharmacological intervention includes monitoring your PT and INR, monitoring your vitamin K intake, and your diet. So education, fetal well-being, surveillance, referrals, and follow-ups. So for your factor V Leiden, patient counseling would include maintaining a healthy weight, proper nutrition, physical exercise, 2.5 hours a week, and smoking cessation. Definitely got to hone in on smoking. I get it. A lot of times mothers are saying, okay, I'm not smoking while pregnant, but if you are a smoker, it's good to still educate like, hey, even in the postpartum phase, please, let's figure out a way to stop smoking. Low molecular weight heparin during pregnancy, postpartum, and breastfeeding. A lot of times they're not going to give you that oral anticoagulant, and then prophylaxis is suggested. And then there's a 4 to 6 week anticoagulation after therapy that is necessary to be compliant with. Referrals, you would definitely be referred to a hematologist as well as genetic counseling to figure out where down the line this mutation occurred, so that if you were to get pregnant again or your offspring develops a disorder, you can become educated as to what the disease is, how to be compliant, what to do, when to do it, and why to do it in a sense. So definitely will refer you to that to get the education. Fetal well-being surveillance, you're definitely going to do genetic testing and a lot of lab draws. So you're definitely going to figure out, does this baby have it? And if they do, what medication the individual needs to be on. And for follow-up, it's not typically necessary for factor V Leiden, but it is necessary to reevaluate after the 4 to 6 week use of an anticoagulant postpartum to monitor your symptoms and your compliance. If onset of symptoms with patient would be advised to be seen immediately. If you get a new onset, your symptoms progress worse, definitely don't hold off and wait. Be seen immediately, call your doctor and say, hey, this is what's going on. For your protein S and C deficiency, So patients on warfarin needs blood work to monitor their INR and their therapeutic range. The therapeutic range should be between 2 and 3. You want to monitor your vitamin K intake and factors that could interfere with your medication, as well as that could definitely cause more trauma to what's going on. You want to be educated on the disease itself. You want to know what the disease is and what it all entails. You want to be educated on the medication compliance, as I keep speaking that over and over again, as well as educated about the risk of the disorder being passed off to the spring. Same thing I said for factor 5 lighting. You want to be educated and well aware and equipped if your fetus was or your offspring was to develop the disorder. So you both need to be aware, educated, and in the know. That goes for whoever the support system is, or the mother, father, the baby. Fetal well-being surveillance. I read a case study that they did a brain sonography, CT, MRI, venous sonography, electrocephalography. I just totally butchered that, but you get the point. CVC, PT and INR, your D-dimer, your liver, and your renal tests. For your fetal, you definitely want to make sure that you're covering all aspects, because the fetus is not well developed, or, even if you have the baby, you just want to make sure their organs are not like adults. So they're functioning, but they're not as advanced or mature, I should say. So you definitely want to get an overall picture of the fetus for their well-being, and to understand what is to be expected as they develop and as they grow. So definitely these tests are very prominent and indicated for the fetal well-being. Referral, again, the hematologist as well as genetic counseling is definitely going to be important for the well-being of not only mom, but the baby. And then follow-up. Patient is going to be on a long-term regimen. You're going to have regular follow-ups to indicated to check the blood levels and medication compliance. So it kind of depends on the situation, whether you're going to be seeing 2 times a week to get the INR drawn, or once a month for the INR drawn. A lot of times if the person becomes therapeutic, they're maintaining, they push that 2 times a week to that once a month. But just when you get that little twinge of, oh, your numbers are off, they're going to go back to that 2 times a week, just to make sure that your blood is thin enough to not develop those clots. So that is the main thing that you want to be educated and really push, is to make sure that you're being compliant with your medication, to make sure that your blood levels are at a level where they will not clot. That is the whole point, because these disorders, factor 5 Leiden and protein CNS deficiency, are blood clotting disorders. That means your blood is not clotting as it's supposed to, because you have a mutation in a lot of the missing gene factors that are needed for the clotting factors that your body has. So definitely need to follow up and be well aware. So these are my references, and that ends my presentation. I hope you guys enjoyed. Can't wait to read questions and see what's going on. Thank you.